Thanks very much, Vanya, and thank you very much. I am last and I am least. So I spend 70% of my time as an ID doctor, and I spend 30% of my time in the lab doing micro and viro, and then I spend about 20% of my time doing research around AMR and AMS and how to insert diagnostics into the patient pathway better. I'm rubbish at tech, I'm rubbish at bits of kit, and I'm certainly not as clever as Rob about adapting behavior, but what I like to do is work out where in that patient journey kit goes, and then what the dickens you do with that result. Because if you don't do anything with the result, that really irritates me. I work closely with lots of people in the diagnostic and therapeutic world. I make no bones about that. You can think of that what you will. Now, over the next, I'm told 15 minutes, I'm squashing it, so I'm going to misspeak fast, and I hope my Devonian accent doesn't interfere with me speaking fast. We're going to cover 4 areas. The first is well-trodden, and then we're going to get onto the meat of it. But the problem I have is absolutely and precisely not Andy's problem. Andy stood up earlier and said, we have no resistance in Addenbrooke's. There is no such thing as a resistant pathogen. So Johan's bit of kit that says the name of the pathogen is useful in that context. It is useful in my context too, but the things that I overlay on that are slightly different things working not 1 mile away in the thick of London's MDR, multi-drug resistant gram-negative pathogen fest, which I would argue is worse than Vanya's resistant gram-negative fest, at least in some of the hospitals that Vanya consults in. So when we're talking about ESBL, sure, there's some global variety, but in London, in England, we're looking at what, 15% is the mean, is what S-Power says? I've got 40% ESBLs. When we talk about CREs, the global mean is what? Less than 1%. The S-Power results are less than 1%. Look at my hospitals over here. One of my units has up to 1 in 10 of their Enterobacteriales are CREs. 1 in 10. And the problem I have is that I actually hate the phrase carbapenem-resistant Enterobacteriales, not only because it is inhibitory for it to trip off the tongue, but also because it belies a difference in underlying resistance mechanism. Now, it's quite nice that some of the near-patient molecular diagnostics, like the film array, have the big 5 on there. Lots of other platforms don't. But how can we use that data to actually then enact change? And it's not just Enterobacteriales, is it? With their ESBLs, yes, no. With their CREs, yes, no. It's actually SUD. And one of the things that Tristan put up there was one of his miscast patients had a Pseudomonas in their chopped and changed. I can't remember which way round it was, from TAS to Mero or the other way round, and then the phenotypic side came out and said it was resistant to the thing you changed to. What a shame. Now, the trouble is, any of these near-patient molecular diagnostics will not tell you for SUD what the underlying mechanism is because, well, they all have an AMP-C, don't they? And they all have the ability to upregulate porin loss and efflux pumps. So quite what we're going to do about enabling us to get around this PIP-TAS versus Mero issue for SUD is a problem. But again, I, personally, practicing in London, have horrific issues with this because, again, the S-Power data is what, 6–7% resistance for PIP-TAS, for carbapenems amongst SUDs? Look at my data. In my ICUs, I've got 40–50% of my SUDs are resistant to TAS and Mero, and that's not just because Vanya's been there before me dishing out all of the antibiotics. It's not all Vanya's fault, just most of it. So how do I cope with that? So at the beginning of the day, Dan and Andy stood up here and talked about definitions and ripped apart definitions. But actually, in my mind, what definitions do is allow you to go down that little Markov model decision node in your head of what is my decision here, add in a bit of information. How does this adjust my decision? What is a bit of information? And Dan was talking about how we came up with the phrases community-acquired pneumonia versus hospital-acquired pneumonia, perhaps to help us differentiate between the types of pathogens causing that pneumonia. I overlay different information, as I suspect all of you do, but I just have a slightly different population here, in that I'm overlaying where in the world have you come from? Exactly which hospitals have you been through in London, bearing in mind in my area we have 7 hospitals in 5 miles. Some of the hospitals within my 5-mile area have bad bugs and others don't, and I need to overlay that information on there. And if I get it wrong, then as you know, as everyone knows, that kills people. And whether you're talking about inappropriate antimicrobials for Enterobacteriales or inappropriate antimicrobials for sood causing pneumonia, if you get it wrong at the initial stage, you have an impact upon mortality. But you're all erudite practitioners. So I'm going to run through this. As a thought experiment, you must put your hand up to something. I don't care actually what you put your hand up to. But which of these do you think is the greatest risk factor? Someone calls you, an SHO at 3 a.m. in the morning. Someone calls you and says, I've got this patient, I think they've got a HAP or a VAP, and you run through this list. Which do you think is the greatest cause or the greatest association with risk of your Pseudomonas being multi-drug resistant? Who votes for A? They've got multiple comorbidities, this patient. Anyone voting for A? No. You do have to vote for something, just reminding you that. Who's voting for pre-existing COPD on and off antibiotics multiple times a year for the last X number of years? Who votes for prolonged hospital stay? Who votes for recent quinolone use? Who votes for recent carbapenem use? So we've got a smattering of all of you. So there are loads of studies that replicate this, right? This was done by Prof. Rahman. It was done in a US study. But look at that slint out there. And it's this. It's carbapenem use, which trumps all of those other multiple comorbidities, all of those other lots of recurrent antimicrobials, but all in the community. All a bit of doxy, a bit of a zithro, maybe a bit of a mox, right? It's, have you had a carbapenem before? Yeah? Right, you're at high risk. And that's for sood, though, but what about for Enterobacteriales? So for Enterobacteriales, other risk scores exist. We have transplanted the trips off the tongue GSDCS scoring system from Singapore, where it was developed by Paul Tambay's group. We've validated it across West London, and this is now in our prescribing policies. So you come down in your e-prescribing thing, and then you say, oh dear, what is the risk of this person having a multi-drug resistant gram-negative organism as the cause of their gram-negative sepsis? Bip, 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 bip. Oh, high risk, you need to phone microbiology, or infectious disease, or whoever you want to call. You can't just have your Coamox or your first or second gen cephalosporin. And that's lovely, right? But we all do risk stratification in our head, whether we call it such or we just call it taking a history. But diagnostics offer us the opportunity to adapt antimicrobials, to modify antimicrobials at time zero. We've heard about that all through today. So in the interest of time, I'm not going to skip over this, just to say it's not Tristan's group, it's not just Vicky's group, it's all groups find, like in this multi-centered French study, if you roll out the film array, you make people change antimicrobials, notwithstanding what Rob was saying about there being behavioral issues, but if you roll out the film array, you can modify critically unwell patients' antimicrobials. So actually, do we still need risk stratification? I would argue yes, because of all that adjustment of pre-test probability that Andy was talking about earlier today, with Andy's sloping figures over here. They were marvelous, but you've got to understand your pre-test probability before you start utilizing Yoan's, other companies are available, bits of kit. When you do that, when you either use your risk stratification in your head or you use your diagnostic, and it comes out with this patient has a really high risk of not being a simple Andrew Conway Morris patient, but actually being a complex Luke Moore patient with an MDR pathogen, then what are we going to do about it? Because we're actually starting to reach an area, a time frame, I would argue, where we're almost getting to the stage of a companion diagnostic scenario for antimicrobials and MDR pathogens. Because we've now got such a plurality of broad spectrum antimicrobials on the market, but each of which are slightly better at something else compared to something else. And the degree to which those antimicrobials are better at something than better than something else is dependent upon some discernible, detectable, diagnosable different aspects of the pathogen, be that the bug name or the molecular mechanism of resistance. So if we then approach that and we say, okay, we're entering the companion diagnostic phase of microbiology for this period in the decade, then how can we leverage that through into optimal prescribing? Well, if we're going to do that, we've got to reconcile the different therapeutics that are on option to us and then regress that into some kind of prescribing policy. So we've got, what have we got? We've got Keftaz-Avi, which has been licensed through a pneumonia study that has real-world decrement in mortality, real-world data supporting decrement in mortality for resistant Enterobacteriales and for resistant Pseudomonas. Lovely, okay. But for Enterobacteriales, it's predominantly OXA48. So now we need a bit of diagnostic kit that tells us whether the pathogen's got that. We've got Ceftolozane Tazobactam, again, a phase 3 licensing study done in pneumonia with real-world data saying that, again, a clear decrement in mortality when it's used for Pseudomonas in predominantly respiratory tract infections, right? So we've got Enterobacteriales, OX48, probably Keftaz-Avi. We've got Pseudomonas, probably Keftol-Taz. And we've got Meropenem-Vabel-Bactam, which again has a licensing study in resistant organisms, not specifically for pneumonia relevant to today's talk, but anyway, we can allude that there is some pneumonia patients in these studies, and there's a bit of a benefit here, but really from Merovabor, it's around KPCs. So again, we need a bit of kit that will tell us KPC versus OXA48. We've got Emirelli, which is my new best friend, which has got a licensing study in HAP-VAP and real-world data that shows decrements in morbidity and increased clinical cure for a variety of gram-negative pathogens, including against very resistant pathogens. And then we've got Cefidrochol, which is not a beta-lactamase inhibitor compound, but is a novel cephalosporin. Again, a licensing study in pneumonia. And when we look at that 14-day mortality down the bottom there, which persists out to some degree to a month in improvement in mortality. And of course, that's nice, but it's not the crystal egg for Cefidrochol. The crystal egg for Cefidrochol is actually its utility against NDMs or metallo-beta-lactamases. And here, we've got real-world data now supporting, again, improvements in clinical cure and all-cause mortality when you're using this drug for those agents. So what does that mean? What does that rattle through the new formulary mean for all of us? It means exactly what I said, doesn't it? It means that we've got to have companion diagnostics. We've got to have something that tells us at time 0, do you have a bug, yes or no? If you have a bug, then everything we've discussed today. Is it relevant, blah, blah, blah. If you have a bug, yes, is it an Andrew Conway Morris simple bug with no resistant mechanisms? You can just give your off-the-shelf Pip-Taz, Keftaz, Comox, Keftra, whatever. Or do you need to then reflex into something else? So how do we do that? How do we do that? Well, we do that through all of the implementation science we've been talking through today. We pile on top of that all of the learning from Rob around behavior, but then we also have to reconcile that back to guidelines, right? Guidelines. I hate guidelines, but guidelines exist to support the people who perhaps have not the skill or education to enact bespoke care based upon a per-patient diagnostic. So given that we're here talking about pneumonia today, I think it's worth reflecting upon the NICE guidelines for pneumonia, which you've all read 100,000 times. Now, we've talked a lot today about Pseudomonas. So what I want to do is delete everything in the national UK pneumonia policy that does not kill Pseudomonas. I'm not sure why they were in there in the first place. Then I want you to overlay on that something about your local resistance data. I've done that for my local resistance data. And that kind of means that I've got a 1 in 3 chance to a 1 in 4 chance of getting it wrong first time, the opposite of GERFT, if I observe the national policy. So if I have a diagnostic that says I've got bad bugs, then I have to actually just throw the NICE guideline out the window, right? So instead then I need to go through to our UK treatment of resistant gram-negative treatment guideline, which was put out by Peter Hawkey a few years ago now, 2018 or something. And it was a 78-page behemoth, and for those of you who've not read it, there is one focal flowchart in the middle that Peter put together. Most of it's to do with urine. Delete the bottom bit from your mind for the purposes of today's talk and focus on the middle. Now, if you focus on the middle, you'll see some of the agents that I've been talking about in the little middle bit of my talk where I said these are the weapons in the armory. But of course, 2018 is a long time ago with the change in therapeutics we've had over the market. Over the intervening period. So what instead do we have to reflex into? We've got the IDSA guidance and the ESCMID guidelines. And for those of you who just need a quick recap about the difference, so Pranita Tama put together the IDSA guidance group, which was a group of experts sat in a room. They looked at all of the data. They made no Cochrane-based grade analysis of the weight of the evidence behind their guidance. They just reflected as a group of experts upon the manuscripts in front of them and put out some guidance. Mikkel Paul put together the ESCMID guidelines group, which did adopt a Cochrane-based approach to trying to come up with guidance for resistant gram-negatives. They went through a grade-based classification of all the strength behind the data. So when we practice in the UK, we have the nice guidelines, which don't really work. We have Peter Hawkey's guidance, which doesn't really work. And we have the IDSA guidance from a group of American experts and the ESCMID guidelines from a group of European experts with a framework, right? So let's just then reconcile this last bit, because this is the bit that enables all of the results from all of the diagnostics we've heard today come into a personalized therapeutic approach. So this is it for Enterobacteriales if we were to listen to Pranita Tama and the US group. And what we see here is we see some KPCs, we see some NDMs, and we see some OXAs. And remember what I was saying earlier about a bespoke companion diagnostic approach? This is kind of where we're heading. Look, if you're an OXA48, you do have this. If you are an NDM, this is unlicensed, so you can't really have this, but you can have that. That sounds like a companion diagnostic to me. And then if you've got a KPC, you've got a few more options. The ESCMID guidelines come out with something reasonably comparable for Enterobacteriales, some slight differences, but actually what I wanted to draw your eye to was the confidence in evidence. So after Mikkel Paul went through the very regimented Cochrane-type approach to this, we only find low evidence supporting the ESCMID guidelines, which are vaguely analogous to the IDSA guidelines, at least for the purpose of this. If we flip on then through to Pseudomonas, and we've heard a lot of issues today with Pseudomonas, then actually there's one bit that pertains specifically to Pseudomonas outside of the urinary tract. Weird American phrasings, we'll not forgive them for that. But by outside of the urinary tract, and you're talking about Pseudomonas, we're basically talking about what we're all here today to talk about, which is pneumonia. And they say Keftol Taz, Keftazavi, or Imirelli. But that again will depend upon some kind of diagnostic test. And if we flip on through to the ESCMID guidelines, this doubles down on that companion diagnostics I was talking to you about earlier, because they've got rid of everything. There is no plurality of option here for ESCMID difficult to treat Pseudomonas. There is just Keftol Taz. So we can very nicely go back to that table I showed you just before from Yohai Doi and say, okay, we can now go and pick a per bug and per resistance output antimicrobial based upon those diagnostics. Right, you said 15 minutes, that was 16 minutes. I apologize, Dr. Gant. But what I wanted to cover there was a whistle-stop tour of my world, different to Andy's world. I suspect some of you have a smattering of either nice, kind of rural Cambridgeshire or urban grime London, somewhere in between those two. I think what we've talked about, how initial inappropriate choice has an impact upon mortality. Yeah, sure, we all knew that. But actually, how do we avoid that? We either avoid that through risk stratification or diagnostics, but then we've got to then take those results of either risk stratification or diagnostics and overlay into that overlay into that some kind of understanding of the evidence base behind these new, novel, expensive antibacterials and how they reconcile with our national and the relevant international guidelines. And I'm going to stop talking there.
Thank you very much.